Immunotherapies are approved in metastatic colorectal cancer for patients with mismatch repair deficient and or MSI-High tumors. So there are different ways to assess the mismatch repair deficiency or MSI status of patients. One of the most commonly used screening methodologies is immunohistochemistry for the 4 critical mismatch repair proteins, which really flows very nicely in the workup of tumor specimen. Actually, de facto right now, independent of stage and age, every colorectal cancer is being tested for mismatch repair deficiency. So we have the result, including actually virtually with the pathology report right up front. MSI testing requires a PCR reaction. So we look for the length of the microsatellites. It's kind of a consequence of the presence or absence of the mismatch repair proteins that we test for with immunohistochemistry. Now, next-gen sequencing testing also gives us microsatellite instability based on algorithms that have been established from various companies, including actually liquid biopsy companies. They can now also read out an MSI status in a lot of these tests. So I think for our practical purpose, however we slice and dice it, whatever tests we use, we identify patients for the usefulness of immunotherapies. There might be not perfect overlap, not 100% overlap, but I think the concordance is good enough that whether we identify patients with immunohistochemistry, PCR reaction, NGS, it doesn't matter. We can use immunotherapy in these patients.
Every patient with colon cancer should have microsatellite instability testing, whether that's a patient with a stage 1, stage 2, stage 3, or stage 4 disease. The implications of MSI testing can vary based on the stage. For stage 4 disease, it's more for treatment decisions. For earlier stage disease, it's more to define if the patient, for example, has Lynch syndrome or not, or should be screened for Lynch syndrome. In our institute, every single patient with stage 4 disease will be tested upfront for microsatellite instability. We use immunohistochemistry, looking for MLH1, MSH2, MSH6, and PMS2 as our screening tool. However, in addition to that, every single patient in our institute undergoes next-generation sequencing testing. And our NGS panels using Ashion, or also known as GemExtra, or when we use Foundation One, and there's other panels such as Caris as well, all these NGS panels include microsatellite instability within their panel. So practically speaking, some of our patients are tested in 2 different ways rather than 1. But I think it doesn't matter how you test it, it's important to test it. Certainly there may be discordances sometimes between immunohistochemistry and PCR and NGS panels. It appears to me that when you couple the data regarding tumor mutation burden and the microsatellite instability status, that's when you have even more confidence that your immunotherapy is going to be a good option for your patients.
As was mentioned in my practice, the primary decisions on the basis of MSI-High and its presence or absence. I don't explicitly order TMB, although I'll use the NGS panel testing results to really look for ultra mutators that may not be captured on the MSI results. There is a mutation in the pol epsilon or pol E most commonly. There is some pol D, but those are fairly rare. But the pol E's, which are also uncommon, can result in a much higher tumor mutation burden, even greater than what we see in MSI-High. As a result of that, sometimes you can get actually secondary MSI loss if you're testing by proteins. In that setting, those are patients that we think benefit from IO therapy. But I think we also have to be really reticent, and I don't see evidence of activity of these kind of borderline elevated TMB. Sometimes on the report they'll say TMB moderate high or high when they're MSS. So those patients, there's really no evidence that in a large number of patients will benefit from a PD-1 inhibition. So I think I don't necessarily order the TMB because in those settings the TMB doesn't add anything for those borderline patients. So we're certainly always exploring about what is it in MSI-High that may play a role in predicting response. I think we're more comfortable saying what doesn't predict response to a PD-1 inhibition in an MSI-High tumor. We know that BRAF mutation, which is commonly seen in MSI patients, does not associate with response or resistance. We also know that the presence of a hereditary syndrome, Lynch syndrome, is not associated with a greater or lower response rate compared to a somatic MSI. And there's been data that's been demonstrated that PD-L1, which is obviously an area of interest in many other tumor types, is not at all predictive in the setting of MSI, which is kind of intriguing of why this may be different, but there's really no signal that that's relevant. In my practice, we're using PD-L1 inhibitors, commonly in combination with CTLA-4 inhibitor in second line or earlier. I think increasingly hopeful that administering this in patients earlier, such as in the first line setting, will provide benefit. It should be noted, however, that this has not yet been shown. We're hopeful that we'll have data about this, but that we don't know yet about what the impact of immunotherapy in first line for that is. There's hope that, as in the COMET study that's the COMMIT study that's ongoing, that we're asking the question about whether or not the combination of a PD-L1 with chemotherapy may be better than chemotherapy alone. And there's a completed study looking at PD-1 inhibition versus chemotherapy that's completed enrollment and awaiting results.
When we talk about immunotherapy for colorectal cancer, MSI-High, mismatch deficient colorectal cancer, there are two main options: pembrolizumab single-agent therapy and nivolumab plus minus ipilimumab. This is where we have data, and the initial data that we saw very early on were pembrolizumab based, and that generated a lot of excitement. And I think a lot of people now use pembrolizumab as one of the defaults in a later line setting in MSI-High colorectal cancer. Now, we have seen data here and at the ASCO GI conference, at ASCO and other conferences, that the combination of nivolumab plus ipilimumab in a first-line setting in 45 patients, actually, data presented by Heinz Lenz, very intriguing, high response rate, high durability of response. I mean, the median overall survival isn't reached, median progression-free survival isn't reached after more than 1.5 years, 2 years. So that is intriguing, and I do believe that the trend will go toward using immunotherapy in first-line treatment. And in my clinical practice, and I always try to treat patients the way I would like to be treated, if I had an MSI-High colorectal cancer, I would potentially like to see nivolumab, ipilimumab. The combination with ipilimumab is always a little bit looked at, higher side effect rate, etc. But the combination they are used is actually low dose ipilimumab every 6 weeks, not every 3 weeks, as in other standard dosing. So I think this is very well tolerated and highly effective. So pending the results of randomized trials, I think this is going to be the way forward.